Morning, guys. All right, we're going to go ahead and get started. Happy Monday. This morning, we're having our journal club presented by one of our third years, Dr. Posada. So I'm just going to share our screen and we'll get started.
Thank you, Sam. Take over. All right, good morning, everyone. Juan, for those of you that don't know me yet, I think everybody knows me here. This is going to be the journal club presentation I'm going to do. I'm a PGY3, and basically I'm going to present a clinical trial. Basically, it's based on the management of CAD on patients that have advanced kidney disease, specifically patients that have moderate and severe ischemia. So these are the authors of the actual trial, and this article is actually published in March of this year by the New England Journal of Medicine. And this is the reference for the article. For those of you that would like to kind of like see it, I guess they sent it already, so you guys must have it. Just before I start, if you have any questions, if you would like to have any comments or say anything, please go ahead. I want to make this as interactive as possible. So as far as the background for this study, there are several things that they kind of like looked into that made them make this study. The first thing that they noticed is that cardiovascular disease is the leading cause of death in patients that have CKD. And as we know, CKD is an independent risk factor for CAD, such as hypertension and diabetes are. Typically, patients that have CKD, just to go off the background, they do have a very significant risk for developing coronary artery disease. And the reason why is because they have a dysfunctional endothelium, they have a lot of oxidative stress, and these patients have higher levels of homocysteine. Of course, they have similar comorbidities to CAD, independently from CKD itself, such as hypertension sometimes, diabetes, and all these things combined can actually lead to CAD. And typically these patients, when it comes to imaging, stress tests, and all these things, they have less sensitivity and specificity to determine whether they have significant ischemia. And typically, when it comes to revascularizations for these patients, they have a high risk of having kidney injuries when it comes to contrast. When you do PCI, even with drug-eluting stents, they have a very significant risk of restenosis. And those patients that have CABG, even though they have less tendency to have the risk of requiring revascularization again, they do have an increased mortality and morbidity after they have a CABG. So these patients are a very difficult subset of population that called the attention of these authors, and that's why they decided to do this study. They noticed that the presence of kidney disease has been associated with an increased risk of procedural complications, as I mentioned, typically AKI from coronary angiography and revascularization. When we're talking about coronary angiography, we know that we have contrast, and that leads to contrast-induced nephropathy. When it comes to revascularization, if you are doing PCI with stents on those patients that have significant atherosclerosis with high burden, those can dislodge, they can travel, embolize, and they can lead to kidney damage as well. And then they noticed that it was uncertain whether doing just conservative management versus all these interventions could result in a long-term benefit. The reason why is because most trials that have been done for people that have CAD, when they compared invasive strategies versus conservative, they actually either included very few patients that had CKD, or they actually excluded all the patients that had CKD. So it was kind of hard to determine how these could be extrapolated to these patients. So they also noticed, as part of their background, that they saw a study that was done in 1992 where they involved 26 candidates for kidney transplantation, and they were actually given, revascularization. And they noticed that on these patients, they had a lower risk of cardiovascular death overall. And they also had lower risk of myocardial infarction than those patients that were only on medical therapy. However, at that time, 30 years ago, the medical therapy that was standard was nifedipine and aspirin. And as we know, things have evolved. And on the last 30 years, both medications have changed, and also the techniques and the procedures, all these things have actually been improved over the last 3 decades. Now, basically, the trial name is Ischemia CKD. Basically, this stands for International Study of Comparative Health Effectiveness with Medical and Invasive Approaches, Chronic Kidney Disease Trial. And this chronic kidney disease trial is basically an adhesion to the actual study that is called ischemia by itself. And basically, this study was conducted to see whether there was an incremental benefit for invasive strategy in those patients that have stable coronary disease with moderate or severe ischemia in advanced chronic kidney disease. So, as a parenthesis here, the original trial, ischemia, basically just to go over it just briefly so you guys know what it basically determined. It was published in the New England Journal of Medicine as well this March of this year. Basically what they did is that they compared the same thing, patients that had stable coronary artery disease and they had moderate or severe ischemia, and they wanted to see whether the clinical outcomes were better for those patients that had medical therapy plus invasive strategies versus those that were only on medical therapy. And this study randomly assigned about 5,000 patients that had this significant amount of ischemia, and when possible, they did angiography and revascularization, and they compared that to medical therapy. And basically what they determined here is that the initial conservative strategy versus the risk of ischemia wasn't any difference on the outcome. And they followed these patients for a median of 3.2 years. This particular study actually excluded patients that had CKD. So when they were doing the study, they determined, what about if we do this for these patients that have CKD as well? That way we can actually use data for this particular subtype of patients. So the trial design for this ischemia CKD trial basically is an investigator-designed international randomized trial. Basically, they enrolled patients that had advanced kidney disease with an estimated GFR that was at least lower than 30, and or the patients were already on dialysis. The trial was designed to determine, again, invasive versus invasive plus medication versus just conservative strategy. And those patients that were on medical therapy, angiography was only reserved for those that had failed the medical therapy. Basically, the enrollment of this trial began approximately 2 years after the original trial with ischemia, and they ran in parallel to each other, and they were conducted at almost the same sites. So this trial was funded by the National Heart, Lung, and Blood Institutes. Something very nice that I found when I was reading it is basically no industry sponsors were actually associated with this. Obviously, that takes out a lot of conflict of interest, and basically the statistical data and the coordinator center was here at Duke Clinical Research, and New York University were the ones that were the coordinating center for the clinical trial. So when it comes to eligibility and procedures, basically, eligible patients, as I mentioned, they had advanced kidney disease with moderate or severe myocardial ischemia, and this was determined by the site investigators using different techniques. So the patients that were on the ischemia trial originally, the way they determined whether they had significant ischemia and if they had significant obstructive coronary artery disease was by doing CT angiography, CT coronary angiography. And this was actually not done in this study for obvious reasons. When we're doing angiograms, we're doing contrast, and that obviously increases the risk of these patients to develop an AKI. So they didn't do this. They used more than anything stress tests, whether it was imaging stress tests or the vitamin echo, things like that, which have less sensitivity than the CT angiography. Now, these patients who met the eligibility criteria, they were randomly assigned into both categories in a 1-to-1 ratio, and they were treated with the initial invasive plus medications versus conservative. So these are basically the characteristics of the patients. As you can see, those are all the demographics as well as the risk factors, comorbidities. Just to give a few examples, the average age for all patients were in the 60s. The vast majority were males, such as when Victor presented his journal club, he also mentioned something that caught my attention here as well, which is the vast majority of the patients were white. There's, of course, minorities are not as represented as we can see with the other population. We see right here that ischemia was mainly moderate rather than severe, and they also had these comorbidities that were highly prevalent, such as hypertension, diabetes, and a few others. When it comes to previous interventions, not too many of them really had interventions. PCI, only 19.1% of patients, much less CABGs. The EFs were typically normal for these patients, and the vast majority of them didn't have renal transplantation. Those actually, of the patients that had, of course, CKD, at least half of them were already on dialysis. And from those patients that were on dialysis, the vast majority were in hemodialysis rather than peritoneal dialysis. And the estimated GFR on average was about 23 for most of the patients. So when it comes to what they did here, basically they selected the patients for CABG or PCI, and they basically try to do the intervention, the angiography and intervention within 30 days of randomization. Um, Now, those patients that were given medical therapy were also moved into the PCI or CABG group when they either had non-obstructive coronary disease. I'm sorry, those patients that were on the CABG group or PCI were moved to medical therapy when they found them to have non-obstructive coronary disease, when they had diffuse small vessel disease, and this was left to the discretion of the treating team. Something that I liked about this particular study is that they created this heart kidney team, which was basically composed of an interventional cardiologist, a general cardiologist, cardiac surgeon, and a nephrologist. And they use several strategies to reduce the risk of kidney injury, which actually, when we go ahead and review the actual data, showed a few things that were quite interesting. So they use a customized hydration protocol for these patients. So as we do sometimes here, specifically for patients that have CKD, more than anything when we're in cardiology, those patients that we're going to send for contrast imaging, when we're going to do angiographies, we try to pre-hydrate them if we can. And typically, it is better if we do this for about 24-hour windows, so we can do 8 hours prior to the procedure, 16 hours after, and that's something similar to what they did in the actual study, just to prevent contrast-induced nephropathy. The other thing is that basically they try to use contrast volume threshold based on the patient's estimated GFR and body weight. They use protocols and PCI techniques that involved ultra-low contrast volume or even no contrast at all. And those things actually had a very significant outcome, which I'll tell you later. Now, in the conservative strategy group, they actually were moved into going for an angiography and even intervention, if possible, for those patients that had already failed medical therapy. Similar way that they did with the patients that were going initially for the invasive strategy, but they had non-obstructive coronary disease. They were moved to medical therapy. These patients that actually failed medical therapy were moved into intervention. So those are the patients that actually develop an acute coronary syndrome. Of course, they were moved into the cath lab. Patients that develop heart failure, as we do, we try to do ischemic workup. That includes sometimes getting angiography and revascularization. Um, they also did this for patients that have resuscitated cardiac arrest and angina that was refractory to medical therapy. Now, the medical therapy basically was the same medications that we typically use for these patients, beta blockers, aspirin, statins, and they also kind of recommended very intensive secondary prevention with lifestyle modification as well. Now, the patients were followed at months 1.5, 3, 6, and 12 after randomization during the first year, and then every 6 months thereafter. When it comes to the trial outcomes, we have a primary and a secondary outcomes. The primary one was basically a composite of death or non-fatal myocardial infarction. The secondary outcome includes the same things as the primary outcome, but it also adds hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. This study actually used the Seattle Angina Questionnaire and Canadian Cardiovascular Society Angina Class, which are basically scores that are given to these patients to determine the angina-related quality of life. And I'll show you that in a table in a few minutes. The safety outcomes for this particular study were the initiation of dialysis in patients who were not receiving dialysis at baseline and a composite of newly initiated dialysis for that. So this right here basically is a continuation of the first table that I show you. These are the baseline characteristics of the patients. When it comes to these scores, we have the Seattle Angina, we have this Canadian Cardiovascular Angina class. This Seattle Angina Questionnaire basically resumes into a score that is called the IQR. Basically, the IQR is telling you how many episodes of angina they have daily, weekly, or monthly. And the vast majority of these patients had either monthly angina or they had no angina at all. But if you combine the monthly or daily or weekly combined, it's a little higher than no angina whatsoever. When it comes to the Canadian Cardiovascular Society angina classes, how much or how was the limitation for the patients based on the degree of angina? So, for example, these patients, we can see right here that most of them were class 2, which basically is a slight limitation of physical activity. And then they also basically categorize them by the New York Heart Association. As we know, 1 is like no symptoms at all, 2 is like slight symptoms with like strenuous exertion, 3 is basically, yeah, just with moderate exertion, you already have some symptoms. And you can see that no one was right here, which is kind of correlating to the fact that most of them had normal EFs. When it comes to the type of stress testing that was done on these patients, you can see that most of the stress testing was basically nuclear imaging, and the other one was like echo, most likely the butamine stress echo. And we can see that they didn't do much exercise stress tests, and they excluded cardiac MRI. I'm assuming because these will require contrast, and as we know, gadolinium, I don't know if I'm pronouncing this right, the contrast that is used for MRI, actually for those patients that have end-stage renal disease, is an increased risk for this condition known as nephrogenic systemic fibrosis, which is basically a condition where they have a lot of like infiltration on the skin, thickening, and even internal organs with fibrosis and end organ damage, which is basically not a good thing for these patients. So when it comes to statistical analysis for this particular trial, they originally planned to recruit about 1,000 patients, but they had slow recruitment, and they ended up recruiting about 800 patients total. The outcomes were analyzed according to the intention to treat principle. Do you guys know what the intention to treat principle is? So we have two different principles when we're basically comparing this data. So we have as treated and intention to treat. So as treated is basically we have two groups. Let's say we have placebo and we have the treatment group. And then let's say the placebo group patients, they say or they hear that the intervention is better than the placebo and they switch along the way in the study. If you do as treated, that means that you're actually going to analyze the data when they moved into the final group, and that doesn't really help preserve randomization. In this particular intention to treat, you keep the patients as they were originally. So that means even if they switch, let's say at the last 4 months of the study, but the previous 2.5 years, they were consistently in one group and you collected data from those patients, that means these patients are going to be analyzed that way. So that helps to prevent randomization, which helps to improve the power of the study. And they use the Cox model where they adjusted pre-specified baseline covariates. And these covariates are basically like confounders and things that can actually alter the result of the statistical analysis. And so we have age, sex, kidney function. And basically what they did is that they adjusted these covariates so that our data is more clean and we can actually interpret it. And the Cox model is basically allowing you to analyze the data as you go. So that means every certain period of time, because this is a time to event analysis, they will follow the patients and basically they will collect data about their outcome, let's say death or MI or whatever happened for the patient, and you can actually collect the data as the study is going. So that's why they use this. So further information about baseline characteristics. Basically, these patients were followed between, or were enrolled between April 2014 and January 2018. A total of 800 patients were enrolled in the trial. Of these patients, actually 777 underwent randomization. They were divided half and half pretty much between the invasive strategy group and the conservative strategy group. As I mentioned on that table before, the median age was about 63 years old. This was conducted in 118 sites in about 30 countries, and about 50% of the patients had diabetes. About 53% of the patients were receiving dialysis. The EGFR, as I mentioned on the previous table, was around 23 on average for these patients. And they had a frequency of angina that was consistent with at least several times per month, we can say. As I mentioned, the qualifying stress tests included the different types of stress imaging, such as the nuclear stress imaging or echocardiography. And this was done in about 81% of the patients. Only about 18.5% of the patients actually did an actual exercise stress test. And severe ischemia was present in about 37.8% of the patients. Most of them actually had moderate ischemia. So the type of medications and attainment of risk factors goals were similar in the two groups. Basically, the medium level of LDL they mentioned in the study was about 83 per baseline, and actually ended up being about 70 in the last visit. When it comes to the median systolic blood pressure, there was a slight decrease at the end of the study. They went from 135 to 130. They noticed that there was more use of anti-anginal medications in the conservative strategy group, and that makes sense. If you're not doing interventions, you're not relieving the destruction, most likely these patients are going to still have angina, so they will likely need more medication. And they also noticed there was more use of dual antiplatelet therapy in the invasive strategy group, which also makes sense because if you do an intervention and you're doing a stent, most likely these patients are going to be on both medications. So when it comes to the invasive procedure, this trial actually did an actual coronary angiography in about 85.2% of the patients. And the reason is a few patients, they were not able to do it because 5% actually had significant illness or death, or 60% of the patients at least had patient preference of not doing it. From those patients, those 85% that did angiography, only 50% actually had an intervention, composed of about 85% PCI, 15% CABG. And they only found multivessel coronary disease in about 51% of the patients, and involvement of the left anterior descending artery in about 57.2% of the patients. So they noticed about 20% of the patients didn't have obstructive coronary disease, which basically can let us know that the strategy they used, such as imaging, compared to what they used in the CKD trial, which was coronary CT angiograph, actually had lower sensitivity for detecting these patients. So they were actually bringing a lot of people to the invasive strategy group that didn't really have obstructive coronary disease that they could not intervene on. Follow-up, basically, only about 4 patients withdrew from the trial. That means more than 99% of expected patient years at follow-up were completed, so that's pretty good. And the median duration of the follow-up was about 2.2 years. So when it comes to the actual outcomes, the primary outcome, which if you guys remember is non-fatal MI or death, occurred in very similar frequency in both groups. So 123 in the invasive strategy, 129 in the conservative strategy. We can see right here that also is about 30% of the patients on each group, 120 from 300, about 30%. And we see that the confidence interval actually falls, both numbers falls and they surpass 1. That means that they're not really significant, and I'll show you that in a graph in a second. And the key secondary outcome, very similarly to the first outcome, showed very similar outcomes for both particular strategies, with an adjusted hazard ratio that was 1.1, 1.01. You see the confidence interval right here also showed that it surpassed 1. So that means it was not statistically significant. So we have the graphs right here where you can see both primary and secondary outcomes. And you can see the same thing that I just showed you, the adjusted hazard ratio didn't really show clinical significance, statistical significance, sorry. And you can see both groups actually had very similar outcomes on this particular graph. So when it comes to follow-up, they noticed basically on the clinical outcomes that both incidences of death for any cause and cardiovascular death were high and similar in 2 groups. There wasn't really any significant difference on myocardial infarction, hospitalization for unstable angina, or hospitalization for heart failure. This is like supplemental data that they found in this study. For example, there was a higher increase of incidence of stroke on those patients that had intervention, but it wasn't really a very significant, incidence. So they had only 1 event in each group that was separated or that was randomized. The incidence of death or initiation of dialysis in patients who were not receiving dialysis at baselines was higher in the invasive strategy group. And also, they noticed that those patients that were not receiving dialysis at baseline and actually ended up having contrast, whether they were going to get an angiography by itself or PCI, they noticed they actually had an increased risk of going into dialysis, like 7.9%, but it was actually much lower than the previous studies that they had actually analyzed, where they had very significant higher rates. This is just a table showing all the outcomes, comparing them all. Basically, most of them were very similar. The only one that I showed that was quite different was the stroke. We showed a little bit of a higher incidence on those patients that had invasive strategy versus those patients that had conservative. And basically the same here. All these data was very similar in all groups: death, myocardial infarction, hospitalization for unstable angina, for heart failure. This is basically the secondary outcome on its own. And no significant difference was noted. This table right here, very similar to the one that Victor explained on his last journal club. We can see basically this is the cutoff for showing whether this is statistically significant or not when it comes to the hazard ratios and confidence interval. And as you can see, all of this data, this is blocking it, but all of these numbers, basically it includes 1. So none of these categories were actually showing any particular statistical significance. And all these lines, basically, when they cross this middle line right here, is showing that they do not, basically, they're not significant. For example, if we had this degree of baseline ischemia with severe ischemia on these patients, and let's say this line right here was further this way, not crossing this line, we can say, yeah, this is actually something that demonstrated that the invasive strategy was better for those patients. But I mean, we didn't really find any difference. So basically, just a few more things to cover for the discussion. Um, Okay, so basically, as we mentioned, the same outcome, no difference between one or the other. They actually went back and they looked into previous studies, and they just wanted to see what the data was on these patients that had chronic kidney disease, and it was quite limited. They found that the three studies that were mentioned, for example, the Courage, basically compared the clinical outcomes of revascularization with aggressive drug evaluation, but these actually only enrolled about 16 patients with advanced kidney disease. The FAME trial was also another trial. This only included 20 patients that had a creatinine over 2. And then they also did this other study that they review, which is the BARI 2D, which basically is angioplasty revascularization investigation in diabetic patients. And they actually excluded patients that had a creatinine that was 2, greater than 2. So based on that, consequently, what the article concluded is that we could not really use all these data from those previous studies to be actually applied for patients that have CKD, because we know, as I mentioned, all the complications that are associated with CKD patients, such as higher risk of procedural complications. They have reduced long-term durability of revascularization. They have a higher degree of restenosis. They also have a rapid progression of atherosclerosis disease, as I mentioned before. They have a high risk of death from non-atherosclerotic causes as well. And as they mentioned, it was not justifiable to really use all the previous data that we had on these studies that actually did not include CKD patients for these patients. And of course, like I mentioned, the ischemia trial actually had excluded CKD patients, so that's why they went ahead and they added these patients. Just a few extra information about the statistical analysis that was more like supplemental data that they found in these patients. They noticed that by doing all these strategies of before they were giving contrast, like using low volume contrast, adjusting to the EFR, the pre-hydration protocols, they actually had a lower incidence of dialysis, as I mentioned, about 7% for the invasive strategy group. They noticed that on the prior studies that had those little patients that had CKD, about 30 to 60% of these patients actually ended up developing an AKI or going into dialysis. So that's actually pretty good data on like this type of interventions when you're doing this. The other thing is that, yes, the invasive strategy group actually had a higher incidence of dialysis initiation. However, when they actually followed these patients for 2 years in total, they noticed that the patients that were on either group, they ended up on dialysis anyway. So, I mean, that's something that they found as well. Something important they mentioned as well is when it comes to why is it that we screened all these people and we only revascularized about 50% of the patients. And the reason is, as I mentioned, there's reduced accuracy of stress testing when compared to the CT angiography that was done on the ischemia trial. Sorry. When it comes to the ischemia trial, they were able to screen out about 20% of the patients that didn't show coronary obstructive disease. So that helped with their data as well. Just a few caveats that should be considered from this trial is that they actually excluded patients that were quite symptomatic, so such as patients that had heart failure, recent acute coronary syndromes, those that had EFs that were lower than 35%, and for that reason, we cannot use the data collected from this particular study for those patients. And just to finalize, basically, we know that these patients didn't have any difference between doing conservative versus invasive strategy. So the take-home point here for these patients that have CKD is that sometimes less is more. Sometimes we may push them, or we would like to go ahead and do all these interventions and try to relieve the obstruction, particularly when they're very symptomatic. But doing so doesn't really, or is not proven yet, to be better than just doing conservative therapy for these patients, as is being shown in this trial. And that's pretty much it. Thank you. If you have any questions, please go ahead.
All right, thank you. So I'll just put the code up now and we're good to go. Thanks guys for coming. We're good.